we decided to do a lecture from someone who's experienced about things they've learned in their practice, because in keeping in the theme is like, can we kind of translate some of this knowledge that's been acquired, over long periods of time? And we couldn't think of a better person than Ziad Hijazi. Ziad is very well known all over the world. He runs the largest pediatric interventional cardiology symposium, and I think has a very unique North American and now out of the U.S. experience, and I think we really look forward to hearing him give his lecture. Thanks, Ziad.
Good morning, everyone. Thanks a lot, Eric. And again, I want to thank the course directors for inviting me and for putting on this great course. So certainly, over the last many years, as Lee mentioned yesterday, you need to listen to those people with some of the gray hairs. He has more gray hair than I do. But it depends. It's the quality. It's not the number. So let's talk about this. So this is my disclosure slide. And the way that I wanted to convey the lessons that I learned over the years is through some cases that I went through. And I wish that, there are some cases that I went through, but I did not actually have access to the angiograms before because of my move. But certainly some of those cases would have been actually great to discuss them here. But nonetheless, I think I have enough 5 cases that I can show you how really they taught me a lot. So the first case was a case with a large ASD. So as Zahid mentioned yesterday, complex or large ASDs, it has different definitions, but in my opinion, a large ASD, any ASD in any body over 25 millimeter by 2D TEE, or if you are not worried about the size, it's in relationship to the septal length or diameter larger than 2/3. So this is a patient from Argentina. That's why I'm wearing the T-shirt. This kid, 16 years of age, pretty intense basketball player. He did not want to have open heart surgery. So his family from Argentina contacted all famous interventional cardiologists in the United States, and everybody, when they saw his TEE, they said, no way, you should have open heart surgery. So mom, contacts me, and I looked at the echo. I said, well, you know what? There is a good chance that we can close it. So as you can see, the ice here, pretty large defect. With this balloon sizing, it measured about 38 millimeter. So I said, you know what? We'll choose a 38 millimeter. You can see with the ice, the rims are pretty deficient. This is the RA, and this is the LA. And you can see very, small left atrium, but in any event, so I took him to the cath lab. I do it under conscious sedation. And we did the balloon sizing, as you saw, and we decided to implant a 38 millimeter device. And then there's the device, and it looks slam dunk. I said, wow, what are these people talking about that they could not close his ASD? So there's the device deployment. It looks pretty good, nothing residual shunt at all. And I go out of the room. I told the family. Of course, they already have prepared the gift for me. So a nice gift with a thank you card, Dr. Hijazi, for saving him from open heart surgery. So
the blue tie or the red tie?
I don't actually remember exactly, but it was a good gift. And they were staying at the Four Seasons downtown Chicago. So. Good. So this is the EKG the next day. As you can see here, what do you see? First degree heart block. So I said, this is not a big deal, first degree heart block. Let's watch this. And this is the next day. They live downtown Chicago, which was about 1.5 miles from Rush University Medical Center. So I said to them, and they're smart family, I said, go to the hotel, and if you have any symptoms, just call us back. So the EKG here, what do you see? complete heart block. So we said, come to the hospital. And now, of course, I started to become worried. Come to the hospital, and we're going to treat with what? Steroids. We said, we'll give, high-dose steroids, high-dose aspirin, hoping that this heart block will resolve. We treated for 7 full days, and the EKG did not really change at all. And now 7 days, the family started to become anxious. They're staying in the Four Seasons. It's becoming expensive. So finally, I kept the gift in the office. Finally, I said to myself, let me talk to the family and see if they will agree for open heart surgery. So we said, you know what, and Zahid remember because he was on service, let's take him to the OR and remove the device. The problem or the issue, of course, you don't know whether if you take him to the OR and remove the device, will this become reversible or not reversible? There's no guarantee, right? So it's really a gamble that you will take, because somebody will say maybe leave it and put a pacemaker. But as I mentioned earlier, he wants to play basketball. He is a big, competitive basketball. So we took him to the OR, and the surgeon, when he inspected the atrial septum, so on the right side of the septum near the cock triangle where the AV node is, as if you were scratching it with something. And that's, of course, from the right atrial disc. So it's a trauma to the AV node, and they removed the device, closed the ASD, and sinus rhythm, right? So then he comes to the unit back, and then within the next 2 to 3 days, started developing post-pericardial syndrome. Huge effusions, and stayed for a week in the hospital. And this kid, it was a nightmare, basically. So this case, what I learned from it is basically, when he came and I said, what my colleagues are talking about, this is, because we close Large Asd. Respect the opinion of other colleagues if they say this, and be humble with your opinion when you see that. So eventually, he did very well, and then he went back to Argentina. Second case, another ASD. We do a lot of ASDs. So this is an ASD with either a clot or infected tissue. So the question is, when you take this patient to the cath lab, would you dislodge something and cause a stroke or disaster? So here is the history of this lady. 55-year young lady. She's a lawyer, number one. She had cardiomyopathy and VTAC. So they put an ICD in her, and then she developed staph infection of the lead. So they treated that, and they decided to remove the lead. When they removed the lead, as a result, they yanked the atrial septum and caused a large ASD. This happens, guys. These things, iatrogenica imperfecta. So they caused a large ASD, so she was treated, and then now, of course, the EP guys are coming to me, Z, would like your help to close this defect. I said, looked at the echo, the TEE, and saw the ASD. So we'll show you now. So the ASD measured 17 by 20 millimeter secundum, and there was mobile tissue from the inferior septum. Was it infected, not infected? I'm not sure. So we took her to the cath lab, and I'll show you now. These are just the images. Let me show you the actual movie. So look at this here. So you can see some tissue there. This is ice again. There is the tissue. Again, not sure whether it's really just touch it like this, it will dislodge and go to the brain, causing disaster. And there's the shunt. So honestly, I was doing it, my heart rate was at least 150 because I was so scared that it will dislodge and cause a major disaster in this lady. But, because of her history and what happened to her, I decided, let's just cross this defect and pray that nothing will happen. And that's what happened. So crossed it, nothing happened. We went ahead and actually closed it with a device, and this lady now is at least about 6-7 years post-closure and has done very well with total remodeling of her right ventricle size and that tissue. Once I put the left atrial disc, I was relaxed that, okay, nothing is going to go now across. So this ASD, really what I learned from this ASD is the courage that, obviously be careful, but how can you be careful there when this tissue is in front of you? You have to be determined and strong and courageous to decide to cross and say, let me close it. The other alternative, of course, is open heart surgery, but with her history, we did not want to do this. The third case, an embolized device. The question is, who should you call to bail you out if you decide not to retrieve the device? Or the alternative, should I persevere and remove the device? And here is the story of this guy. 29-year young man, was known to have a heart murmur for many years, presented with shortness of breath, palpitations, was evaluated, and they found that he had atrial flutter. In this case came from Michigan. So this was in Michigan. So they took him to the cath lab there, and actually he had a stroke from the procedure, unsuccessful, and hit him with left-sided stroke. So then he was referred to our center for ablation as well as for the ASD closure. So we said, sure, why not? So we took him to the cath lab to close him. He had the flutter ablated successfully with no problem. And then a few days later, we decided to take him to attempt the closure of this mega ASD, 31 by almost 40 millimeter ASD. At that time, this case was done, I think, 2011 or 10. We were trying, no, even longer. This case was 2006 or 7. We'll see the echo now. We were trying the 3D TEE from Philips. Roberto Lang, John knows him, was leading the efforts in that time on 3D technology with comparing with ASD. So we took him to the cath lab, and here is TEE images, of course, showing pretty large right-sided. There's an angio, massive left-to-right shunt. You can see the TEE probe. And these are also nice TE images showing you the defect, a very large defect. And this is ICE images. Now I was doing simultaneous ICE. You can see with the ICE, really not much of rims at all. Look at that. Very large defect, 40 millimeter. Look at that. Somebody told me yesterday they have a 50 by 70 ASD. I'd like to see that. This is the 3D TEE. So there are some rims. You can see that. Not bad. Deficient. So I said, you know what, we can close it. We tried multiple times to align the device across the defect. Finally, after multiple attempts, and I'll show you this now, we were able to secure the device and position it nicely. So there's the Hausdorff sheath. This is another good thing that you need to keep in your cath lab in the US. Outside the US now with the occlutic devices, you really don't need a Hausdorff sheath because of the pivoting of the but in the US, definitely you need the Hausdorff sheath. So tried multiple times, retrieve, reposition, because, deficient rims. There's no rims at all. And these are just 3D images showing you the device. Attempt at the left upper pulmonary vein technique with a Hausdorff sheath. No. So then, and you can see his rhythm, he started to have some wiggle, another attempt, and then, nope. Right up on the vein, and this looked good. So with this one, we said, wow, we got it. This is the largest device, 38 millimeter. Now this is actually the 40. I was evaluating the 40 millimeter device, and you can see this is 2007. And then the device looked good. So we said, okay, guys, release. So we released the device, and then we noticed his EKG, he went into atrial fibrillation / flutter. So the device looks in good position, with ICE, looks good, catching here, everywhere. Stupidly, I decided, let's zap him, get him out of the flutter. So you can see the flutter there, ICE, good position, and now we're gonna do the DC. So all evaluation indicated device in good position. You all agree, right? And then we zapped him and the device there. So I went ahead with a snare, actually captured the disc and brought it back to the right atrium. I'll show you there is the disc now flying, there is the snare, got it there. I did not want to change the harder sheath, and it would not come through the 12 French sheath. And I did not want to oversize the sheath. I said, you know what, I'm not going to close it anyhow because I'm going to send him to the surgeon. So we called the surgeon. Our congenital surgeon was not in town, and the adult cardiac surgeon said he'll take him to the OR. So I said, okay, I went to talk to the family, and I went to my office. They went to the OR. So I asked my colleague, Dr. Chow, many of you know him, go upstairs, check and see how are they doing. It's an ASD. So he called me, he said, Z, you've got to come to the OR. I said, why? He said, the patient is not doing well. I said, what? It's an ASD. So I went there and honestly looked at the abdomen of the patient. The abdomen was pretty large. I said, guys, what's going on? They're transfusing him. They said, he's hypotensive. I said, why? They said, well, we did fem bypass and thoracotomy. I said, why would you do that? He said, we don't want to give him sternotomy. So I said, can you expose the groin? And they exposed the groin, and the iliac cannula was not in. So quickly they called the vascular surgeon. And of course, when they realized this, they abandoned the thoracotomy, which was open, and they went median sternotomy to put him on bypass right away. So now he has thoracotomy, median sternotomy, and the vascular surgeon comes and, of course, has to explore the groin for the cut down. And, of course, the minute the vascular surgeon held the iliac artery, the blood pressure stabilized, and then the surgeon closed the ASD. So I said, before you leave, we've got to do TE, make sure that there's no residual ASD. So the residual ASD was about 10 millimeters. I said, go back on bypass, close the damn ASD. So he went to the bypass and closed the residual ASD. The patient was stable, but nonetheless, he had a thoracotomy, a sternotomy, and an iliac artery cut down. Right thoracotomy and fem bypass, arterial and venous cannula were inserted, cut down, and all of this. So this is the device which was removed, and then this is the defect, closing it, and then I don't, show the picture, and so, but this is the patient. You can see here, sternotomy, thoracotomy, and then of course the groin is down here, the iliac artery cut down. So this case, the patient eventually, did very well. Actually, went home in a few days and did extremely well, and follow-up is good. So the lessons I learned from this case: number one, if you embolize a device and you don't have the right help, persevere and remove the device percutaneously. Nothing worse sending somebody urgently to the OR, especially when your congenital surgeon is not there at all. Right? So these are important lessons that I learned since that case. If I embolize something, I do my darn best to solve the problem myself, as long as the patient is stable. Fourth case is stent implantation with dissection. I showed you this case yesterday, so I don't want to go through it. This is the lady from Saudi Arabia had, I put a covered stent and ended with dissection. So, and we used to make the covered stents like this in our lab. Now we have the stent graft. So this is the patient. So there's the angiogram, straightforward, severe coarctation / acquired atresia. We put the covered stent, and there's the covered stent. Positioning was nice, no problems. Inflated, you can see. Oops, shoot. Let me just go back here. And scroll it faster here. So please scroll it faster. Okay, so you can see that there is still extravasation. I expanded this end, hoping that I will tuck it against the wall. We did that, but still there was stuff. So the case that, the lesson I learned from this case, first of all, collaborate with other people, specifically IR or vascular surgery, because they have equipment that you may not have readily available in your lab. And in this case, specifically the stent graft, you can see it here, very nice results. So I urge you to collaborate with IR, specifically for stent grafts and also for embolization therapy. They have coils that you don't know how to use all the time because it's rarely that we use them. And now all my coronary fistulas, I do not go and establish arteriovenous loop and do all of this. And all retrograde through, or 4 or 5 French sheath only, no matter how big it is, using target detachable coils. And the IR people are the experts in these cases. Last case, erosion. And the last lesson I learned is you need to educate your patient about potential complications. This lady, 26 years of age, she came to us from Florida. She had multiple ASDs, slam dunk closure, no problem. So we closed her defects with 2 devices. And then exactly 2 years and 2 weeks after the closure, she calls the hospital, my hospital from Florida, complaining of sudden onset of chest tightness. And those are the symptoms that actually we taught her. We said chest tightness, chest pain, fainting, call right away. Luckily, she got hold of my cardiologist on the weekend, on Sunday, who called me right away and said, immediately, let somebody take you to an emergency room and do a transthoracic echo. And thank God, that's what they did, and this is what they have found, near tamponade. So obviously, they had time, actually, because she was stable, to take her to the cath lab. This is Elsa. Some of you know Elsa. So there is the angiogram. They did an angiogram, and you can see 2 devices there. And if you look carefully, the large device, the left atrial disc, was protrusion into the left atrium, into the aorta, causing erosion and perforation, basically. And, of course, in retrospect, this case, the large device was a little bit oversized, because when I did the case, the erosion issue was not there. So this case, the erosion happened 2005, so I did the case 2003. We were just about discussing erosion. So it was an oversized device. The lesson learned from this patient, always, when you do an intervention, educate your patient about potential complications and what could happen to them and how to seek advice. And I hope that these 5 lessons, you will learn from them over the years and become a better interventional cardiologist. And thank you.
So I think we can open it up if there's any questions or comments about anything you see there or anything you want to say.
Clear lessons, right? Yeah.
What do you tell patients about erosion risk?
Every ASD I do, this is one of the discussion without any question or hesitation or fear, that, you have about 2 to 3 per 1,000 chance that you will have erosion. And I tell them that the good news that the mortality rate is even less. It's about 2 per 10,000, right, Zahid, mortality from the erosions. And I tell them, in contrast, open heart surgery, if it's done by a non-congenital surgeon, the mortality rate is about 2%, not 2 per 1,000, 2%. And of course, there are other risks involved with that. So I educate them and tell them it's your choice, and I educate them about the symptoms. And I have never had a family say, well, no, we want to go and do surgery instead of device.
You get families in New York all the time. I mean, you say erosion, they go for surgery.
Well, New Yorkers are, they're weird people.
Or they'll say, can you take me to the lab? I want the Gore device. If you can't do the Gore, then I'll go to the OR.
They're not educated.
Well, I don't know.
That's the perception from many of the cardiologists in the area, that they
Yeah.
are so scared about having a patient. So yeah, you've got the risk of postpericarditis syndrome and everything else. They're so concerned about the unknown timing of erosion, like your case, 2 years later, versus,
Well,
okay, you're gonna have surgery, there's a good likelihood you're gonna have an effusion, you probably need to have a pericarditis diseases afterwards, but once you get out of that month, you're good. And they'll come in.
Yeah.
You can put in the Gore device, I'll do it because it's never had the erosion, doesn't know what they do for. If you think you're gonna have to use that, depending, especially on the deficient rims, they just say go for surgery.
yeah, I mean, there's no question that the Achilles heel of transcatheter of ASD is the unknown timing of the erosion. But nonetheless, we have been successful convincing families that, this is the right thing to do.
As a sort of a corollary question, not necessarily about ASDs, but how do you deal with parents? How do you deal with parents that spend a lot of time on the internet and get a lot of bizarre information, some of it right, some of it not so right, and then come into your office and say, Dr. Jazzy, you know, I just read this article on the internet, and I want this done or that done.
This is in binder B, tab 6.
Tab 6, yeah. So, quite honestly, I mean, a lot of the families that we deal are pretty well educated. They serve the internet. And, I sit with them, I say, listen, not everything that you read on the internet is correct, or the way that you understand it may not be this. And I tell them, in our hands, this is what we do, and this is what are the risks and stuff like that. And at the end of the day, they all feel comfortable and proceed with the intervention. But it's a, interesting discussion, difficult discussion sometimes, especially when parents are lawyers or something like this.
Yeah, do you give them enough, well, I mean, in our institution, or at the TGH sick kids, we always say, well, here's our opinion, and we'll make an arrangement for you to sit down with a surgeon and speak to them about it, and then you can decide whether you want to have an operation or an intervention.
Quite honestly, I find it sometimes awkward to sit with a surgeon in the same room and counsel a family. Yeah. So I tell them that if you would like to meet with a surgeon, please, feel free. I'll arrange an appointment with a surgeon. But I believe strongly that this is the way to go, not the surgical. I don't advise them to go and seek a second opinion from a surgeon. No, because they're going to tell them what I tell them, but they will do a twist on it, and then you confuse the family. And we are the patients' advocates. We should gear them to whatever we believe strongly that this is the right way. But if you make the family make the decision, they get confused. It's tough. You can gear a family to do whatever you want them to do. So if you believe strongly that this is the treatment of choice in this day and age, it's easy job. But if you don't believe, that's when you confuse them, and that's when they need more opinion and more opinion. There's no need for that.
One of the things that I do, I usually tell them, you can always quote all the risks, potentially consequences, right? I always tell them that you're subjecting your child to my hands. I will give you mine.
Yeah. And I think that's, and not only that, I tell them, listen, that I am a father, a brother, and everything. If this is my child, or you're my wife, or you're this and this, that's what I would do. And once you do this, they believe in you, and then they'll say, let's proceed.
So, actually, question for the audience. You have a child, your child, 28 millimeter ASD. They're 17 years old or 18 years old. They finished growing. Who would refer them for a device? Anybody not?
Well, you don't have surgeons here, Eric. Because I can tell you, if you have surgeons in the room, they all will say surgery.
That's not true.
I don't know.
Not Emil. Emil is different. Honestly, Emil is different. Many surgeons, they scare the hell out of these families. They scare them. They tell them the erosion, the death, and the timing. And of course, if you say these things to the family, every family say, open heart surgery.